Hi, my name is Abdulrahman Nimeri. I'm the Director of Bariatric Surgery at Brigham and Women's Hospital, and I've been performing bariatric surgery for almost 2 decades. I perform laparoscopic and robotic procedures, and those include sleeve gastrectomy, hand-sewn Roux-en-Y gastric bypass, duodenal switch, procedures for complications or procedures for revision of previous bariatric surgery. Today, it will be my pleasure and privilege to introduce you to the members for the Center for Weight Management and Wellness and introduce you to our team.
Hello, my name is Dr. Carolina Povian, and I am a co-director of the Center for Weight Management and Wellness at Brigham and Women's Hospital, and I'm also a professor of medicine at Harvard Medical School.
I'm Dr. Christopher Thompson. I'm the Director of Endoscopy at Brigham and Women's Hospital. I'm also the co-director for the Center of Weight Management and Wellness, and I'm a professor of medicine at Harvard Medical School. I finished my training here, so I've actually been here about 20 years, and my primary role is performing advanced endoscopic procedures, oftentimes in people suffering from obesity, but as well as in patients that have had complications of bariatric surgery.
Hi, my name is Ali Tavakkoli. I'm a minimally invasive and bariatric surgeon at Brigham and Women's Hospital in Boston. I'm the chief of the Division of General and GI Surgery and one of our co-directors of our Center for Weight Management and Wellness. I have worked at the Brigham and in the field of weight management and bariatric surgery for nearly 20 years.
My name's Eric Hsu. I'm a bariatric surgeon here at the Brigham. I've been here for almost 20 years. And I serve as the chief of the section of bariatric and foregut surgery.
Hello, my name is Neil Goucher. I am the medical director of the bariatric program at South Shore Hospital, part of the Brigham and Women's Bariatric Comprehensive Program. And today I'll be talking about Roux-en-Y gastric bypass for bariatric surgery.
My name is Megan Ariano, and I'm one of the registered dietitians on the team, here to talk about the RD's role as part of your care team.
I'm Beth Anderson. I'm a physician assistant now for 15 years, and my current role is as program coordinator for the Metabolic and Bariatric Surgery Service operating out of South Shore Hospital alongside Dr. Neil Goucher.
Hello, my name is Sandy Falcon. I'm one of the physician assistants with bariatric surgery and also the chief PA for general and GI surgery.
Hi, I'm Mark Gorman. I'm one of the psychologists at Brigham and Women's Hospital, and I'm the Director of Behavioral Services for the Center for Weight Management and Wellness.
Hi, I'm David Spector. I'm the Director of Bariatric and Reflux Surgery at the Brigham and Women's Faulkner campus.
Hi, I'm Dr. Tom Tsai. I'm a bariatric surgeon at Brigham and Women's Hospital and Brigham and Women's Faulkner Hospital. I also serve as an assistant professor of surgery at Harvard Medical School and assistant professor in health policy and management at the Harvard Chan School of Public Health. My clinical practice focuses on metabolic and bariatric surgery, as well as the surgical treatment for heartburn and acid reflux. My research focuses on health policy, generating data to improve the care of our patients, and I direct the Healthcare Quality Outcomes Lab at the Harvard Chan School of Public Health.
Hi, I'm Ashley Vernon. I'm an assistant professor at Harvard Medical School, and I've been a surgeon here at Brigham and Women's Hospital for 20 years.
Hi, my name is Dr. Malcolm Robinson. I'm Vice Chair of Clinical Operations here in the Department of Surgery, as well as a bariatric surgeon. I've been doing bariatric surgery for over 20 years.
I'm Dr. Scott Shakura. I'm a bariatric surgeon at Brigham and Women's Hospital, and I'm the past president of the International Federation for the Surgery of Obesity and Related Diseases.
Metabolic and bariatric surgery has changed significantly in the last 2 decades. These surgeries treat a disease that is no different than cancer. Obesity leads to type 2 diabetes, high blood pressure, high cholesterol, sleep apnea, and major cardiovascular events. It even leads to cancer. Today, we know that obesity is a silent killer. But you need to know that obesity is 60 to 70% genetic, and that our biology drives many of the complications and the causes of this disease. Yet today there's significant bias and stigma that exists about the disease of obesity. At the Center for Weight Management and Wellness, we want you to know that your weight issues will be taken care of regardless of your BMI, your age, your sex, or your medical problems. You will get a holistic treatment that includes behavioral and lifestyle changes, medications, bariatric endoscopy, and sometimes metabolic and bariatric surgery if it's the right thing for you. In this video, you'll hear from several clinicians from the Center for Weight Management and Wellness. They are all members of our multidisciplinary team. They will take you through the process of evaluation, the process of workup, and if someone undergoes surgery, how do they get treated before and after surgery.
And we now understand that these do not work by merely an anatomic restriction of the gastric pouch and malabsorption of food. That is not how these procedures work. These procedures work by changing the secretion of gut hormones. Which gut hormones are we talking about? We're talking about ghrelin, which is the hunger hormone that is secreted right before you eat by stomach cells. These hormones are now seeing less food more quickly, and you feel full, and your brain tells you, because these hormones go to the brain, your brain tells you that you are full and you don't need any more energy. It also, these satiety hormones also increase your energy expenditure, believe it or not. So in other words, what these surgeries do is allow your body to defend a lower body weight by 100 pounds or more in this environment. And that's really how surgery works. Now, we've learned all of this about these surgical procedures, and we have developed, the pharmaceutical companies have developed analogs of some of these hormones. And we are able to produce these hormones, these analogs, and package them in an injection, weekly injection, that you can we give to our patients, and they can defend a lower body weight as well. The body weight is reduced with these injections by 15 to 20%. Now note that bariatric surgery really reduces your body weight by 25 to 35%. So if you really need to lose 100 pounds or more, or 80 pounds, then really bariatric surgery is the procedure for you and not these medications. These medications are great for people who need and want to lose 15 to maybe 20% of body weight. So these medications are analogs of GLP-1. This is one of those hormones that produce satiety. It's only one, and that's why you're not getting the kind of weight loss that you can get with bariatric surgery, because bariatric surgery alters many different hormones. These once-a-week injections can help people lose weight, and at the end of a year, it's about 15 to 20% weight loss. Another newer medication is called tirzepatide. You may know it as Mounjaro, and this injection is producing 22% weight loss. So as you can see, we're clearly getting very close to the sleeve gastrectomy, but for many patients, not close enough.
We have a variety of bariatric endoscopy procedures that we do offer. We have primary endoscopic weight loss therapies that are used for people that have not had any surgery. So those include things like intragastric balloons and endoscopic sleeve gastroplasty or ESG stomach tightening. We also have several procedures we offer for patients that have had either an endoscopic procedure or a surgical procedure and then suffered recurrence of weight gain. And so we have those procedures, and we also have procedures that are tailored for the treatment of complications following bariatric surgery. Bariatric surgery is very safe, and we do recommend that. Even with very safe procedures, sometimes adverse events will happen, and endoscopy offers a minimally invasive way of treating those adverse events. So it's oftentimes better than going in for a repeat surgery. And we have ways of treating leaks and ways of treating other issues. The recurrence of weight gain is something that we do focus a lot of our attention on. It's wonderful working hand in hand with endocrinologists, the surgeons, and the whole team of dietitians. And I think it's also something that's unique about our center because we're all under the same roof and we're working together. So a patient might come in and they might think that they want an endoscopic procedure. And after talking with them, they might be better off having surgery or maybe a medical option. And the patients don't have to wait. We have surgeons right there in the clinic with us and endocrinologists, and they'll just kind of, we'll have them come in the room and discuss what other options might be available. So it's really wonderful kind of working in that multidisciplinary environment. I think it's great for patients, and it's something that I think we should all aspire to do more of.
I feel really fortunate to be part of the team at the Brigham, not just because we deliver excellent clinical care, but because we're really at the forefront of research in this field. And our research really focuses on two areas. One is to make surgery better, safer, and more effective. And we're interested not only in short-term safety and effectiveness, but also long-term outcomes, issues of weight regain, studying why that happens and how we can optimize long-term weight loss for our patients. The other area that we're interested in is how surgery works. And the goal there is to understand the mechanisms through which bariatric surgery helps with reduction in weight, helps with diabetes improvement, helps with metabolic health, and then try to think of less invasive alternatives that we can develop to replicate those effects. In the Laboratory for Surgical and Metabolic Research, where I still work today, has continued. But over the last 2 or 3 decades, our focus has really shifted to what alters a healthy metabolic balance that can lead to obesity. And over this several decades of research, we've started to identify distinct pathways that I think are dysregulated in obesity, and then bariatric surgery helps correct. And we're now targeting those pathways and trying to develop less invasive alternatives that can replicate the metabolic effect of surgery. And I think, everyone knows that surgery not only leads to good durable weight loss, but really this rapid improvement in diabetes, right? We see patients come in who are on multiple medications, they may be taking insulin, we do the bariatric surgery, and within a day, they're going home, many off their diabetic medications or with significantly less medications.
The dietitians will work with patients before and after surgery through individual visits or group appointments. We complete a thorough nutrition assessment that includes a review of your eating patterns, such as the pace of your eating, how often you eat through the day, as well as understand if there are non-hunger triggers of your eating. Before surgery, we'll work with each patient on goal setting to support healthy habits that will contribute to your success after surgery. It's important to review what life after surgery will look like, so we will spend time discussing how eating will look during the first 2 to 3 months post-operatively. During this time, we will also ensure patients are taking vitamin and mineral supplements to minimize nutrient deficiencies. As patients progress through the first year of surgery and beyond, the dietitians will ensure patients are developing and maintaining eating patterns that emphasize nutrient-dense, minimally processed foods. The dietitians understand every patient's journey is different and will ensure we maintain a patient-centered approach that involves not just looking at the scale, but the health benefits patients are noticing.
Our program is very fortunate to offer in-clinic visits at multiple locations, as well as virtual visits to help improve patients' access to care. Our clinics can be found in Boston at the Brigham and Women's Hospital main campus, in Pembroke, Weymouth, Westwood, Foxborough, and Jamaica Plain at Brigham and Women's Faulkner Hospital. We also operate and perform surgeries at several locations, including in Boston at Brigham and Women's Hospital, in Jamaica Plain at Brigham and Women's Faulkner Hospital, as well as at South Shore Hospital in Weymouth. We pride ourselves on offering lifetime support for our patients after surgery. Clinical care follow-up will include routine lab work and visits with our physician assistants, our bariatric dietitians, as well as our bariatric psychologists. We offer a wide range of long-term support. This includes bariatric psychologist-led support groups to cover things like habit forming and any behavioral concerns. We also have in-person and virtual support groups that offer more patient-led conversations. And monthly, we have a forum discussion that includes a wide range of topics. In the past, this has included navigating through the holidays, managing emotionally triggered eating, and things like plastic surgery after weight loss.
Physician assistants are licensed healthcare professionals who are equipped to address any medical issues under the supervision of your surgeon. The surgeon and the PAs work together to review all treatment plans and medication management for each patient. Our focus is on preoperative and postoperative evaluation and management for your bariatric surgery. Before surgery, we'll provide a thorough medical assessment by reviewing your health history and ensure we optimize care for your safe surgery. We will make sure you are informed with what to expect during your hospital stay, as well as early days at home as you begin your recovery.
The role of the psychologist, both before and after weight loss surgery, comes up a lot. A lot of people have a lot of questions about that. So you're seeing me because I'm embedded in the bariatric team, and so I'm working alongside your dietitians, your surgeons, your medical staff, and we're going to talk about not just behavioral concerns that might be going on that might impact your ability to lose weight or maintain weight loss, but also just general mental health, behavioral health concerns that can come up. So there'll be a lot of questions about eating and exercise and sleep, but also just general questions about mood and where you live and how your life's going, just to see if there's anything that we can address to make the surgery safer and more effective for the long term. So a lot of folks come in and wondering, why am I meeting with a psychologist? And part of the reason I'm here is to help you prepare for surgery, right? So I'll be asking a lot of questions about your mood and anxiety and where do you live and what do you do, but I'm also going to get a sense of, as far as your eating style goes, is there anything we need to do to kind of help prepare you to get ready for what we know about life after surgery? So, we know that eating regularly is important. We know that taking your supplements is important. We know that, participating in planned physical activity is important. Are there things that might get in the way of that, or are there behaviors there that we can work together and really kind of do before surgery to, not just help you know that you're going to do well with surgery, but to help us know where your strengths and weaknesses are so that we can kind of focus on areas that need a little extra work. A lot of folks spend time with our dietitians and medical staff learning what to do and kind of why to do it, and sometimes a little extra help with the psychologist on how to do it is why I'm here. A few last minute items, just things that might be important to think about as you're going through the process, is just remember that you're in it with not on your own, that you're in this with a whole bunch of other folks helping you through the process, and that might be some other patients that you meet through the group work that you do or through some of the educational forums that we provide, but also just to keep in mind that you're here with your dietitians, your psychologists, your surgeons, your medical staff, and you're not facing this all alone. We're here to help you through that process. None of us expect it to go completely smoothly. There'll be bumps in the road, but you have a whole team here to help you in the long run.
So the sleeve gastrectomy is the most commonly performed bariatric operation in the US, and here at the Brigham, about 80% of patients choose it. It's an operation where through a series of very small incisions with the camera, we go in and remove the part of the stomach that makes hormones that help your body regulate hunger, fullness, and how it responds metabolically to diet. So with that, patients are able to lose a good amount of weight, on average 25% of your starting weight at the low. And it works very well in terms of durability and success. Yeah, so for some patients, the sleeve isn't the best choice because even though it has very minimal serious side effects in the long term, the one that does occur in some people is a worsening or development of heartburn and reflux. So if you're starting off from a place with bad reflux, the sleeve might not be the best choice for you.
The role of bariatric surgery is more than just about weight loss, and specifically when we're talking about the Roux-en-Y gastric bypass, we're talking about an operation that has historically had the most impact from a weight loss and bariatric standpoint, and it's the operation that we compare other surgeries to when we're coming up with new operations. The gastric bypass is typically done laparoscopically. The benefits of the gastric bypass are that it both is a restrictive operation in the sense that you're not able to eat as much at one sitting, but it also has a lot more impact metabolically. So you're not absorbing as many nutrients. There are hormones that are being altered, and that affects hunger, that affects how full you feel, it affects cravings, and the most dramatic impact is in diabetics, where it actually is changing the way insulin is produced, the way sugar and other nutrients are metabolized. And that's the biggest reason why we think all of these operations, but specifically with the gastric bypass, why people not only have initial weight loss, but they have really durable weight loss. We expect with the gastric bypass that people should lose about 35 to 40% of their excess weight. The weight loss is expected to be slightly higher than with the sleeve gastrectomy, but slightly lower than with the duodenal switch, so it's kind of in the middle. There are other medical issues with this type of surgery outweigh the short-term risks of the surgery itself. So when deciding, which operation might be more beneficial to you, it really comes down to a couple different factors. And again, when we decide between the gastric bypass and sleeve, there's usually two specific questions that I ask. One is about diabetes. As I mentioned, the gastric bypass might be slightly more beneficial in the long run for diabetics. And heartburn or severe reflux disease. The gastric bypass is going to be a better operation for patients that suffer from severe heartburn and may actually treat it on top of the other benefits of the bariatric surgery.
We all do general bariatric surgery in our group. I also do foregut surgery, which is everything that has to do with hernias, paraesophageals, and basically we do revisional bariatric surgery. I do revisional surgery and weight loss. I do most of the weight loss revisional surgery at this time in our group. And so the three things, bariatric surgery, reflux surgery, and the revisions of those operations is what I do. And we have now decided to introduce two new operations that are part of our armamentum of operations we offer. I've gone and trained on it. We have a new addition in our group that also does these operations. And these operations are called the duodenal switch and the SADI'(S) or -S, SADIs. Basically the same operation, and the types of patients that benefit from these new operations are what we call very large people, meaning BMI that is at least 50, but even probably higher than that, as a consideration for it. Another type of patients that would really do well with these operations is the patients who have really, really bad diabetes, because the anti-diabetic effect of the sleeve is well established and known. The bypass is more anti-diabetic as compared to the sleeve, and the duodenal switch and the SADIs are even more anti-diabetic in its effect as compared to the two other operations.
At the Center for Weight Management and Wellness, we really focus on providing a multidisciplinary approach using precision medicine, tailoring all of the available treatment options to our patients to really customize the care plan for each individual patient. For patients who are high risk, we want to explore all the options available to them, whether it's medical treatment with pharmacologic medications, endoscopic treatment for weight loss, or surgical options. A major part of what we do is to use evidence-based guidelines and the best data evidence, such as the MBSA QIP risk calculator, to tailor individual risks and their outcomes to make sure that we can provide the best information to guide individual patient selection for surgery or discuss other options. For patients who are high risk, part of the risk often comes from their underlying cardiovascular, heart, or lung conditions. And we want to minimize the risk of anesthesia. And so for some of those patients, both endoscopic options or surgical options may need anesthesia. So we will work with our obesity medicine colleagues to start with medications first. We really believe in an all of the above approach in our program, not either or. And for a lot of these patients, it's not just about accepting their risk, but working with the patients and working with their care providers to reduce their risk and get them optimized before any surgery. Just as we think about rehabilitation and recovery after surgery, we also focus on prehabilitation, making sure the patients are ready and prepared for surgery. So for these high-risk patients, we will engage in a multidisciplinary discussion every week where the obesity medicine specialists are there, our GI colleagues are there, and the surgical team to develop a comprehensive plan, which often involves starting with medications to ensure that their diabetes is under control, that they're as optimal as they can before surgery, and at that point, they're may have been higher risk, but then now their risk has been reduced for the best outcome after surgery. A major focus of what we do at the Center for Weight Management and Wellness is to ensure that we focus on the patient's experience of care and streamlining their care through our program. And we really focus on patient choice. Patients have the option of in-person visits or virtual options. And this can occur through the comfort of their own home through the Patient Gateway app, where they can access their laboratory results, their patient schedule, make changes to their appointment, and also make telephone calls or video visits directly with any of their care providers, whether it's the surgeons, the dietitians, or the psychologists. Our goal is to make sure that patients can access the care how they need it, when they need it, and where they can get the care most efficiently. Brigham and Women's has been a national innovator in delivering new ways of improving care for our surgical patients. And one of these exciting programs is a surgical home hospital program. And the idea is that we basically bring the home into your home and let you recover in the comfort of your own home. So for patients who meet the criteria for the home hospital program, after undergoing their weight loss surgery, they're transferred from the recovery room back into their home, where they're met with a comprehensive care team of home hospital providers, which may include physicians, advanced practice providers, nurses, and paramedics who do a comprehensive intake for the patient. The patients receive all the care that they would receive otherwise in the hospital. This includes IV fluids, IV medications, and state-of-the-art monitoring. Our program employs a vital patch, which allows real-time monitoring of your heart rate and breathing rate, wireless blood pressure cuffs, wireless post-oximeter cuff measurement of your blood oxygen levels, to ensure that we have the same level of monitoring and vigilance to make sure that you have the most successful recovery at home. But you can do this all while sleeping in your own bed, eating at your own table, and sitting in your own chair in your living room. So this is part of our way to apply the most innovative technology, the most advanced care plans for our patients, so that they can recover with high quality care, high patient experience in their own homes.
It's been known for a very long time that the operations that we perform for weight loss are the best treatment for patients with diabetes. I first became aware of this in the fall of my surgical internship in 1995, and an important paper came out in our main journal, The Annals of Surgery. The title was, "Who Would Have Thought It? An Operation is the Best Treatment for Diabetes." That paper was really important and showed that patients having gastric bypass for excess weight had significant improvements in diabetes. This really changed the way that everybody thought about operations for weight loss. Since then, many studies have shown this to be true, and this goes for all of the operations that we perform for weight, that there's an important effect on diabetes. And that includes sleeve gastrectomy, gastric bypass, and even more in some of the malabsorptive procedures that our insurers are supporting, like duodenal switch and SADE. We've actually changed the name of weight loss surgery from bariatric surgery to metabolic surgery to highlight this important effect. So we all know that diabetes is an important, significant problem in America. Right now, 10% of the adults in America have diabetes. Unfortunately, less than 1% of the eligible patients receive surgery as a treatment. We then gathered together with 3 other sites across America and were able to pool our patients and follow them for another 7 years. And this important study was recently presented. The data was presented at a meeting this past summer, and the papers will be coming out. It's a pooled, multi-center observational study of lifestyle intervention showing that metabolic surgery is more effective, durable, and patients have less medication than with the medical and lifestyle intervention group. It seems like a win-win. Take care of diabetes and lose weight. Another thing for patients who don't have diabetes, weight loss procedures, metabolic surgery can protect you from developing diabetes in the future.
I've been doing a bariatric surgery for over 20 years, and a colleague of mine and I started the bariatric surgical program at that time. And at that time, we did all the procedures through this big open procedure. I'm really happy to see the evolution over time with respect to bariatric surgery, how we're able to help a ever-growing population of patients, as well as doing it safely and more quickly. But if you are one of those few patients that does have acid reflux or does have weight regain or inadequate weight loss, then the first thing that I like to do is determine whether there's an anatomic or physical reason that we can define. And the way we do this is through two approaches. We are very, very fortunate here at Brigham and Women's Hospital to have what I would call world-class gastroenterologists who have specialized in the area of bariatric surgery. And we would often get an upper endoscopy where they put a scope down the mouth into your sleeve or into the gastric bypass and look for anatomical things. We like to get a complementary test in the radiology suite where we do something called an upper GI study where you swallow dye and it takes several pictures. And again, it gives us information about the sleeve size or about the gastric pouch size or whether there are other issues that we should look for. So if there's no anatomical issue, then we make use of our multidisciplinary team. We're very fortunate at Brigham to have a group of experts in this area that help us with the evaluation of patients. It would start with our nutrition colleagues to do a full nutrition assessment to make sure that people are making healthy choices in terms of their diet. The second thing that we would do is have them go to our medical colleagues, and that we would want our medical colleagues to do an assessment to make sure that there weren't any issues there that we weren't aware of, and to see whether or not a trial of weight loss medications are appropriate for this individual or something that should be tried in those weight gain, or whether there's something that we can do from a medical standpoint to help with acid reflux. And so we want to optimize the kind of non-intervention and non-procedural things in the beginning to see if the least invasive approach is going to be the most effective. And it's only after we've kind of done that assessment, optimized things to the best of our ability, that we would go forward and consider some type of revisional procedure. Just to summarize, our goal is to rule in or rule out anatomic issues, and then based on that, take advantage of our multidisciplinary team to determine what approaches are necessary. And then we escalate intervention from kind of the least invasive to the most invasive to hopefully get people back on track and achieve their weight loss goals.
Well, the previous guidelines were developed by the National Institute of Health in 1991, making them 32 years old. And they're greatly outdated because over the 32 years, so much has changed in bariatric surgery, including the operations, the use of laparoscopy, the better understanding of how to take care of these patients, and everything else. So we were working with 31-year-old directives and guidelines in 2024. So clearly something had to be done. And what we did was we took a writing group from the American Society of Metabolic and Bariatric Surgery and a writing group from the International Federation that I just mentioned before. And working together, we went through all the literature that we could find, particularly the new literature and the better literature, and went ahead and rewrote the guidelines to reflect the changes in how we practice and what operations we perform, how we take care of these patients. And that was extremely successful. It was published simultaneously in 2 journals, and it's slowly making a change throughout the world where little by little these guidelines are being adopted.
We want to thank you for your trust at the Center for Weight Management and Wellness.